Hello, I am Dr. Penny Eggers, Director of Education for the Center for EMS. In this video, we'll explore the differences between obstetric emergencies and childbirth emergencies. I'll guide you through the unique assessment considerations for an obstetric patient and review high-risk, non-delivery obstetric emergencies. Please note that these recommendations are aligned with the guidelines from the American College of Obstetrics and Gynecology and may differ from your agency's protocols. Your instructors will provide detailed information on the specific protocols relevant to your organization. For further training, you can enroll in the complete course developed in collaboration with the Florida Center for EMS, the University of South Florida, and OB physician Dr. Kimberly Fryer. Scan the QR code to get started. Did you know that hypertension is the most common obstetric emergency transported by EMS professionals? Pregnancy-related deaths can happen during pregnancy, during delivery, and up to 12 months after the end of pregnancy. Of all pregnancy-related deaths in the United States, 53% happen 7 days to 12 months after the end of pregnancy, and 84% are preventable. This graphic from the American College of Obstetrics and Gynecology illustrates the causes of pregnancy-related deaths in the United States in 2023. As you can see, hemorrhage accounts for 18.1%. OB emergencies are often associated with the mechanics of childbirth, but they extend far beyond labor and delivery. These emergencies can occur during pregnancy, throughout labor, and even well into the postpartum period. So let's first define childbirth emergencies. Childbirth emergencies occur during the active process of labor and delivery. That is when the baby is descending through the birth canal. Here are a few examples of childbirth emergencies: shoulder dystocia, breech presentation, nuchal cord presentation, precipitous delivery, and amniotic fluid embolism during delivery. Non-delivery obstetric emergencies, on the other hand, include medical or traumatic complications of pregnancy, labor, or the postpartum period, but not related to the physical mechanics of birth itself. Not every emergency during labor is about birth mechanics. Some intrapartum emergencies or postpartum emergencies don't involve the actual delivery process. Remember, obstetric emergencies can occur for up to 6 weeks postpartum, and in the case of cardiovascular disease, for up to 12 months. These are easily missed, especially if the patient doesn't volunteer that they recently delivered. I will review a few non-delivery obstetric emergencies, providing a brief overview of key signs and symptoms. The first one is placenta previa. Placenta previa is when the placenta obstructs the cervix and will cause painless, bright red bleeding, usually seen in the second or third trimester. Placental abruption, which is often trauma-induced, will cause painful vaginal bleeding, a firm uterus, and signs of maternal shock. Ectopic pregnancy typically occurs before 12 weeks gestation and has the classic triad of lower quadrant pain, vaginal bleeding, and syncope or hypotension. Pregnant patients are hypocoagulable, so sudden shortness of breath, pleuritic chest pain, tachycardia, or syncope, you should have a high suspicion of pulmonary embolism. Severe vomiting or hyperemesis gravidarum can lead to fluid electrolyte imbalance. This may mimic sepsis or metabolic acidosis. Amniotic fluid embolism AFE, rare but catastrophic. Occurs during labor or immediately postpartum. Sudden hypotension, difficulty breathing, disseminated intravascular coagulation, or sudden cardiac arrest can occur. Uterine rupture, especially in patients with previous C-sections. Presents with sudden cessation of contractions, abdominal pain, and fetal distress. You may not see external bleeding. Postpartum infection sepsis. Watch for fever, abdominal pain, foul-smelling lochia, or signs of sepsis. Preeclampsia or eclampsia can occur after 20 weeks of gestation and even up to 6 weeks postpartum. Signs and symptoms include hypertension, headache, visual changes, epigastric pain, or seizures. Look for BP greater than 140/90. Even in active labor, seizures or stroke may develop. You may need to manage the airway, control seizures, and position the patient in the left lateral position. In severe preeclampsia, sudden neuro changes or seizures may be due to stroke, not eclampsia alone. May appear for the first time after delivery up to 6 weeks post-delivery. Don't dismiss headache or hypertension just because the patient is no longer pregnant. I want to spend a few extra minutes reviewing the next non-delivery emergency, peripartum cardiomyopathy. This diagnosis is often missed and excused as just a tired new mom. Peripartum cardiomyopathy, according to the American College of Obstetrics and Gynecology, refers to a type of cardiomyopathy that manifests during the perinatal period, spanning from the last month of pregnancy to up to 12 months postpartum. The exact cause is often unknown or idiopathic, but some research suggests it may be related to hormonal changes, autoimmune disease such as lupus, increased blood volume, or stress on the heart during pregnancy. Other factors can include pre-existing heart conditions, hypertension, and infections. Peripartum cardiomyopathy presents with difficulty breathing, orthopnea, and fatigue and can progress to heart failure. Here are some risk factors to consider when making a differential diagnosis for cardiomyopathy. Nulliparity or never giving birth. Extended pregnancy intervals greater than 10 years apart. Obesity with a BMI of greater than 30. Family history of preeclampsia. Advanced maternal age of greater than 35 years. Prior pregnancy complications. Being African American. Socioeconomic factors. Chronic hypertension. Pregestational diabetes. Chronic kidney disease. Autoimmune disease. And multiple gestations. Postpartum hemorrhage is the most common cause of maternal mortality worldwide. It is defined as greater than 500 milliliters of blood loss from a vaginal delivery or greater than 1,000 milliliters of blood loss from a C-section. Postpartum hemorrhage can happen immediately post-delivery and up to days or weeks. Postpartum hemorrhage can occur due to several causes, including uterine atony, the most common cause where the uterus fails to contract effectively after delivery. Trauma, tears or lacerations in the vaginal canal, cervix, or perineum during delivery. Retained placenta. Portions of the placenta remain in the uterus, preventing it from contracting properly. Coagulation disorders, conditions that affect blood clotting, leading to increased bleeding. Uterine inversion, a rare condition where the uterus turns inside out after delivery. Overdistended uterus. Conditions such as multiple pregnancies or excessive amniotic fluid can stretch the uterus and affect its ability to contract. And medications. Certain medications administered during labor, for example, magnesium sulfate, can affect uterine tone. Estimating blood loss can be challenging in the pre-hospital setting. Here is a reference chart to help with the estimate volumes. Note, use a Chuck's pad or towel saturation as a reference. A fully soaked pad or towel is around 300 to 500 milliliters of blood loss as a good rule of thumb. Here is another reference chart to help estimate rate of loss or the presence of blood clots. 1 saturated pad per hour is abnormal. Saturated pads in 15 to 30 minutes is more than likely severe bleeding. That is greater than 500 milliliters of blood loss. Large blood clots bigger than a golf ball or an orange is concerning. Multiple clots in a short period can equal greater than 500 milliliters. A postpartum woman with vague symptoms like weakness, dizziness, or chest discomfort should always trigger a high suspicion of underlying pathology. So how do we apply this knowledge in the field? Here's your advanced level mindset. Don't anchor on labor. Ask every female patient of reproductive age about pregnancy, even postpartum patients. Primary assessment with OB modifications. Airway, anticipate edema or aspiration risk, especially in third trimester or eclamptic patients. Breathing, assess for hypoxia, respiratory rate, and effort. Don't be fooled, an increased rate can be physiologic, but work of breathing or desaturation is always pathologic. Circulation, check heart rate, blood pressure, cap refill, and mental status. Consider the physiologic increase in blood volume in pregnancy, which can mean hypotension is a late sign in OB hemorrhage. Primary survey with OB modifications continued. Positioning, tilt left greater than 20 weeks of gestation to prevent aortocaval compression. This also improves venous return and cardiac output. Disability, neuro, altered mentation. Consider eclampsia, hypoxia, or shock. Look for signs of seizures, changes in vision, and headaches. Exposure. Look for bleeding, signs of trauma, or uterine rigidity. When conducting a focused history on an OB patient, clinicians should think beyond the sample using GTPAL, which is an acronym for gravida, term births, preterm births, abortions or miscarriages, and living children. In the pre-hospital setting, it provides a quick, structured understanding of a patient's obstetric history, helping you anticipate potential complications and guide assessments, interventions, and transport decisions. Focused OB history and thinking beyond the sample for non-childbirth emergencies should be expanded to include gestational age, how many weeks. Fundal height can help estimate if unsure. Pubic symphysis 12 weeks. Umbilicus 20 weeks. Xiphoid 36 weeks. Greater than 37 weeks equals full term. Less than 37 is considered preterm. Lack of prenatal care should raise suspicion for undiagnosed complications, for example, eclampsia, previa, abruption, and diabetes infections. Complications about the current pregnancies such as hypertension, diabetes, placenta previa, trauma, or abruption risk. Asking about last known fetal movement is a critical fetal viability marker. Decreased absent equals sign fetal distress or demise. Vaginal bleeding or discharge can mean several complications. Bright red and painless is placenta previa, painful and rigid uterus equals abruption, foul smelling is a possible infection. Localized sharp or tearing pain may indicate ectopic pregnancy, abruption, or uterine rupture. Asking specific questions in obtaining past medical history should include cardiac, endocrine, clotting disorders, and thromboembolic history. These can help with obtaining a differential diagnosis for non-delivery maternal emergencies such as a pulmonary embolism, peripartum cardiomyopathy, and DKA as an example. Now, we are going to discuss a focused OB history for childbirth emergencies. If time permits, the same questions mentioned earlier for non-childbirth emergencies should be asked, and the following additional questions should also be included: the frequency, duration, and intensity of contractions, as well as the urge to push, are primary indicators of active labor. Contractions and the urge to push suggests imminent delivery. Ask if the membrane has ruptured, how long ago, if they noticed if the fluid was clear, or if not clear, what color was it. This is critical for assessing imminent birth and fetal risk. Let's now discuss some childbirth emergencies. Your instructor will review the specific protocols for managing these childbirth emergencies with you. First, abnormal fetal presentation. There are a few types of abnormal fetal presentations. Breech with buttocks and legs first, shoulder presentation, and a compound presentation with an arm or a leg with the head. Shoulder dystocia is when the head delivers, but the shoulders are stuck. Next is neutral cord presentation. This is when the umbilical cord is wrapped around the baby's neck. An umbilical cord that presents first is called a prolapsed umbilical cord. Finally, precipitous delivery. If the baby delivers too quickly, it can cause maternal tearing and postpartum hemorrhage risk. Effective pre-hospital care for obstetric patients requires focused training in both childbirth emergencies, those involving the mechanics of labor and delivery, such as breech presentation, shoulder dystocia, or cord prolapse and obstetric emergencies, which include medical and traumatic complications like ectopic pregnancy, preeclampsia, placental abruption, or postpartum hemorrhage. Because these emergencies can arise at any stage, during pregnancy, in active labor, or even weeks or months after delivery, clinicians must be skilled in differentiating between them, performing structured assessments, and applying evidence-based interventions. Ongoing education and scenario-based training ensure providers can respond decisively, safeguard maternal health, and ultimately improve outcomes for both mother and child. Before we conclude this video, I want to leave you with a case study for your review and discussion. Your instructor will review this case with you, including the diagnosis and the outcome. This case is based on a real-life scenario. Please consider how you would assess this patient. You are dispatched for a 29-year-old female at 39 weeks of gestation, reporting contractions and spontaneous rupture of membranes. The patient was G2P1 with a history of a healthy pregnancy, aside from early subchorionic hemorrhages. On arrival, the patient reported that she had undergone a Foley bulb induction earlier that day at her obstetrician's office and was experiencing increasingly painful contractions. Shortly after rupture of membranes, she noted a sudden change in fetal movement and increased discomfort. How would you approach the situation? What information would you want to acquire? What are the potential OB emergencies? How would you evaluate and manage this patient? Take a few minutes to discuss. This video was intended to give you a high-level overview of obstetric emergencies. I encourage you to learn more by enrolling in the 4-hour self-paced course by scanning the QR code, which will delve deeper into obstetric emergencies. Thank you so much.